everyone. Welcome to this CoLab Presents presentation on the Innovating Beyond Exclusively Medicalized Approaches by the Canadian Civil Society Advancing Safe Supply. We have Corey Ranger here and myself, Brittany Graham, but I'll let Corey introduce himself and I'll do my intro a little later. Thanks.
Hi, everyone. I'm Corey. I'm a registered nurse. I use he, him pronouns. Today, I'm gratefully joining you from the unceded territory of the Cowichan tribe and what is colonially referred to as Duncan. I'm the president of the Harm Reduction Nurses Association, and I'm a clinical nurse specialist at AVI Health and Community Services, focusing on prescribed safer supply programming. Really excited to be here, and I'll pass it over to Brittany before I start talking more about today's expectations.
Hi, everybody. You just heard my voice, but my name is Brittany Graham, and I'm putting on my other hat, so not CoLab related, but I'm the executive director of the Vancouver Area Network of Drug Users. I've worked there for over 11 years, mostly as a community organizer with the Eastside Illicit Drinkers Group for Education, but have always done a lot of work for Vandu proper. Yeah, excited to be here and to talk about this cool project we work on off the side of all of our desks.
Yes, truly an off the side of the desk experience with this one. Very organic and iterative process. We're really excited to talk to you about it today, and we're going to have lots of time for discussion and question and answers. And we really want this to be kind of a think piece, an opportunity for people to be able to weigh in and give us their reactions and their feedback. I'll give you a little bit of an outline on what to expect for today. Brittany's going to talk a little bit about what the Canadian Civil Society Advancing Safe Supply is, and then a bit about the history of our group, who's involved, and a bit of a windy path that we all took to arrive at this policy brief. And then I'm going to talk and share a little bit about the actual content of the brief, discuss the spectrum or continuum of safe supply models that are in the brief and that could be employed to respond to the drug poisoning emergency. We'll follow that up with a discussion on recommendations from the brief, and then we're going to hear from you, both for your questions and for us to hear your feedback and insights. I do want to acknowledge before I go any further that we are right now in this very moment in the worst iteration of the toxic drug poisoning emergency here in BC and across all of so-called Canada. 21 people per day are dying, and the drug supply continues to evolve and become more volatile. My heart goes out to all of you who are grieving the loss of your loved ones due to failed drug policy. And all of this is happening, of course, within the context of safe supply and other life-saving harm reduction services being under attack and facing regressive politics. So this is really important that we're here today and to talk about this. Because we need to keep examining pathways to innovate and scale up options for safer supply that are predictable, regulated, and most importantly, accessible. I also want to acknowledge that the work of this informal coalition happened involving individuals and organizations across all of Turtle Island, and we honor the life force of Indigenous people who have had their land stolen and who continue to resist ongoing genocide. Is as important today as it was yesterday, and for time beyond memory, that we acknowledge the harms of colonialism and all of the different manifestations that it takes. Addressing the root causes of the toxic drug supply is deeply connected to decolonization. And I also want to acknowledge that the stuff that we're here to talk to you about today is made possible by people with lived and living experience of criminalized drug use, sharing their knowledge and expertise with us. The civil society that we're going to talk about is comprised of people who use or use drugs, and everything that we have when it comes to harm reduction is because people who use drugs have borne the biggest risk to innovate during deadly public health emergencies, while larger institutions lagged behind in their responses. And so it's imperative that we acknowledge their efforts as well. I'll pass it over to Brittany now.
So who are we? So the name is quite, rolls off the tongue. The Canadian Civil Society Non-Medical Safe Supply Working Group, which was formed after a meeting was held in March 2022 with the federal mental health minister, Carolyn Bennett. There were many different groups that were there, but at future meetings, but this really is related to Mom Stop the Harm. They had a meeting, I think they off the cuff, with Minister Bennett and many other groups like VanDu and Dolph, the Harm Reduction Nurses Association had been looking to have these kinds of meetings around our types of programs that we had been pushing for. Specifically, the Dolph Compassion Club is something that VanDu had been thinking about. And the moms were so gracious to reach out to a bunch of other organizations and said, hey, we got this meeting. We don't really know what to do next now that we have this room where the minister is interested in having future meetings. And we all sort of went, we have stuff to give you and things to say. And we went from there. So it was very organic. I think we can go to the next slide. Yeah, so we've had a couple meetings with the previous minister. I think at the time, from our perspective, I think Corey can speak to his perspective afterwards, but VanDu and Dolph were having a really hard time getting meetings with Health Canada, getting meetings with the federal MMHA related to our Compassion Club, whether it was our Exemption 56 or getting any response related to our SUAP grant. And so we saw this as like a place to have conversations about Compassion Clubs and that specific version of Safe Supply. I think, Corey, you had other things that you were looking to get into the room as well.
Yeah, I mean, I think what was important was that there's a number of us who weren't even getting access to be able to speak to the minister. And so when we received kind of that invite from Mom Stop the Harm, everybody came kind of with a different priority or a different idea of what might be important to talk about. But what we needed to do was make sure that we were on the same page first. And so it required a lot of internal work amongst the group.
Yeah, and I think we kind of quickly realized that there were these national groups that were more likely to get into the room with someone like Minister Bennett, and who had a general perspective as to where we should be going, had created good documents around safe supply, etc. But on the day-to-day changing what's happening in our communities versus Vancouver versus Saskatchewan versus Nova Scotia, it's very different. And so we kind of saw this a way to work together as having these national groups sort of get us into the room, and our smaller, more regional groups were able to provide the perspective of our either evidence or anecdotal experiences to the work that we were providing within those policy meetings. So I think once we did that work, we kind of got into the room, had some conversations, and during this process on the side, we were, the beginning conversations were Minister Bennett wanted to have more space with us. Yeah, let's have as many conversations. Maybe we'll have a monthly meeting. It sounded really productive and possibly would be going in a really great space. But at some point during that process, VanDu was informed that we didn't get our exemption request, and Dolph, excuse me, our exemption request and our SUAP grant. And then VanDu and Dolph made the decision to do a judicial review, which if anyone knows Eris, she likes to call it suing the government. But it's really just saying you didn't do us this, you did us a disservice and didn't look at our process and our exemption as well as it should. And so we need to look at it from a judicial process. And so during that, the stuff changed very quickly, where Minister Bennett didn't necessarily want to be in rooms with Dolph or VanDu. And I think we could have easily let this group fall apart during that time, but because we had done some of those internal discussions beforehand, we were able to continue to be what is the ultimate goal here? It's not to get one Compassion Club, it's to get a system change. So how do VanDu and Dolph continue to be a part of that process, but maybe step back from this specific conversation and maybe we move it into a broader conversation? And that's when we started to recognize our frustrations across the board, is that it's not like we're looking for one tiny pilot project in any of these things, whether it's prescribed safer supply or this non-regulated Compassion Club. We don't want pilots. We want policy changes that allow for system level changes that get people into the system that they want and need as quickly as possible. And so that kind of led us to creating a policy brief that looked at those kinds of recommendations for a broader system change. we did a lot of work, and then we brought it to the minister. It was not really particularly acknowledged, I think, is the thing. And I think we all felt a bit defeated related to this brief. But what was great is that it's a document that hadn't been written before. And so because we were able to spend the time looking at the larger conversation, we could then reuse this brief in other places and see where this would be useful in our work as we move forward. It wasn't something that was for Minister Bennett. It was for our group to form what do we want in our system and how do we want to portray it to any type of government official.
Yeah, it was a bit of a lightning rod event that kind of happened when we were told that, like, the minister wasn't prepared to talk about non-medical safe supply, and they weren't willing to talk to Vandu or Dolph. We had an opportunity there where we could either say, I guess we're not going to do this, or we could have said, I guess we'll just meet and talk about whatever the minister wants. But instead, we hunkered in and came up with a strategy amongst ourselves and actually wrote down on paper what it was that we were looking for. And that was, no, we do want to talk about non-medical safe supply, and you have to talk about that. And we'll talk a little bit about challenging some of the government's kind of weaponized ignorance that they employ when it comes to, like, we don't know how to do this. And so we wanted to put something in their inbox that actually told them how they could do this.
Awesome.
So I'll share a little bit about the policy brief and some of the recommendations. The policy brief, it's also important to note that this is a collaborative writing. This is something that was put together by folks, including AWARE, Sunar Kaput, Vandu, HRNA, CDPC, the HIV Legal Network. A whole number of people contributed to the development of this policy brief. And we spent a good amount of time talking about the limitations of medicalized safe supply. And essentially, amidst a nationwide toxic drug crisis, pharmaceutical grade alternatives to the illegal drug supply are an effective intervention, but they're not reaching the people that we need, and they're not being delivered in the ways that are accessible and culturally safe to everybody who needs and wants access to a safer supply. And in fact, if you need any more evidence on this, in British Columbia, some new evidence is showing about 220,000 people across BC access the unregulated drug supply, and less than half of those individuals would ever even qualify for access to a medicalized program, would ever even qualify for an opioid use disorder. The majority of people are people who wouldn't fit into the existing medicalized models. So we noted that medicalized models of safe supply do produce positive impacts for some people who use drugs, but the reach of existing prescribed safer supply programs make them ineffective as a standalone intervention. So, despite its promises, there's an emerging body of evidence that highlights that access to safe supply remains fractured, uneven, and wholly inadequate. We also note that they are mired in capacity and institutional and guideline related constraints, as well, that many people don't even want to be labeled with a substance use disorder, or nor is that appropriate in order for them to be able to access a safer supply. Moreover, we noted that these medicalized interventions, they do not reflect drug use culture, and therefore will never be accessible to the vast majority of people who want to access drugs, for enjoyment and pleasure and enhancement of their experiences. Ultimately, what we came down to is that the secret ingredient is options, and that people need a host of options available to them, some of which may be medicalized, some of which may be completely demedicalized, but that full continuum needs to be invested in order for us to actually see some meaningful changes in this drug poisoning emergency that's killing over 21 people in so-called Canada every single day. So as such, we tried to illustrate what a potential continuum could look like. And so we actually have to do this for the government. We have to conceptualize what an entire continuum of options would look like. And to acknowledge that there's no benefit in throwing anything out because people who use drugs are not a monolith. What we heard from people who use drugs who were in the coalition was like, no, don't get rid of prescribed safer supply, but add all the other things, add the other 90% of the options that need to be there so that people aren't being squeezed into one particular option. The needs and specific contexts that would bring an individual to one safe supply model versus another changes due to a whole host of internal and external factors. One might need a lot of support and maybe there's wraparound medical care, but as that changes, they should be able to access different models with fewer hoops to jump through. Safer supply has to be accessible, and to be accessible, it needs to be equitable. And therefore, anybody who wants to seek access to the unregulated supply should have an option or an opportunity to access a safer supply. So here's just an example of a continuum that we put together. On the farther to the left, you see things that we already have, or closer to things that we already have through clinical programmatic settings. We know that this is the most studied delivery model, that it is generating evidence for future practice, that there are known benefits for some, but we also know that they are rooted in paternalism and medicalized barriers, that there are flawed metrics for success like urine drug screenings, and that there is a significant history of mistrust due to harms towards people who use drugs, as well as coercive practice. And then as we continue to progress along the continuum, we see harm reduction initiatives like the SAFER initiatives or like the tablet IO programs at the Molson OPS. And we know that these are reducing death for people who use drugs. They reduce the risk of disease transmission. We can see that in the emerging body of evidence that's publicly accessible, and they are a bit more flexible and responsive to community trends. However, significantly underfunded, under resources, and limited capacity and precarious funding. The pilot programmatic model into itself is harmful to many, and we know that we need to break out of that mold. And then we start to veer into categories that we have not yet explored, and that includes public health models, ones where people could use decision support tools so that folks can get access without having to have a one-to-one relationship with their prescriber. I actually see that already happen in BC through the use of nicotine replacement therapy, where people can go to a drugstore and they can fill out some paperwork and get access to 3 months at a time worth of their nicotine replacement therapy in the variety of their choosing. We also see that through the provision and distribution of naloxone, which at one point in time was a Schedule I medication. This is, something that could be easily replicated based off of our learnings from naloxone descheduling and demedicalization of nicotine and cannabis, and has the potential to actually start to increase accessibility. However, there currently exists regulatory barriers for implementation and a significant lack of buy-in from people in power and decision makers. And then as we continue to veer off into the end of the spectrum, we see drug policy reform and regulated supply, which includes compassion club models, legalization, regulation, and retail dispensaries. And we know that these are the potential avenues that could target the root causes of toxic drugs, that could be the lowest barrier, could actually compete with the unregulated drug supply, and acknowledges the fact that people use drugs for many different ways, for many different reasons, and options need to be available to be reflective of those needs. And of course, the harms then is that these programs are still not easily understood or accepted by policymakers, and that there is low political will to endorse these models, especially as we've seen transpire over recent months with the only kind of compassion club that was running at present. So we wanted to put this together, and we wanted to issue some recommendations because we wanted to challenge the weaponized helplessness. What is unique about this work and what we've done right now is that we have a good idea of what's working, and we have a good idea of what is not working. We could talk extensively about the positive impacts of prescribed safer supply, and we could also articulate the limitations quite easily. We can, also have a decent idea of where we would like to be. There's great resources out there and recommendations out there, like the CoP Safe Supply Concept Document, like the Safer Supply Checklist from the Canadian Institute for Substance Use Research, like the Imagine Safer Supply Project from the Canadian Drug Policy Coalition. But what challenging. What is challenging right now is that we have this helplessness from people in power. They have the actual power to make the changes, and we hear from them, yes, we need these things, but we don't know how. Or yes, we need non-medical options, but the Food and Drugs Act would prevent us from doing this. Or we don't have the means to make drugs like cocaine and prescription heroin available. And so we wanted to build some traction and challenge this helplessness by saying, no thanks, we do not accept the premise that your government cannot make changes. You make the laws, you can change the laws. If you don't know how to do this, let's bring in the people who actually do. Who's responsible for drug procurement? Who's responsible for supply chain? And this policy brief can be used as a means to hold government accountable and say, no, there's actually a way you could do this. It's your choice not to. We hope it'll also inspire others to explore this gray area that is the gap between where we are now and where we can go in the future. Did you have anything you wanted to add, Brittany?
Well, I think like the one thing that you pointed out there that I kind of missed at the beginning is that we kind of saw these meetings with Minister Bennett as a place to do that conversation where we were having these like, oh, we're not the people for that. And it's like, we don't want to have that conversation with you. We want to say, okay, Minister Bennett, these are the lists of things that we want to work on. Look through it from your political perspective. What is the thing that is like, where's the policy window currently? Bring in those people from Health Canada or from the Food and Drug Act to our next meeting or the meeting 2 months from now so that we can have those conversations and start moving this forward to see what are you doing? What are your plans? How do we move forward? We're not going to do this at the minister's level. You're not going to be the person doing the work, but we want to have those conversations so that they move forward quicker. And I think that made her uncomfortable because we had a plan of how to move forward. And I think they used the opportunity of the Van Dulf case to sort of slow things down because I think we were really pushing policy in a way that they hadn't seen from the harm reduction movement previously.
I almost made it through a whole presentation without talking while on mute, but here we are. Sorry about that. So what are the recommendations that were issued in this brief? The first was to immediately expand access to existing medicalized safe supply options with emphasis on flexible models that are tailored to consumer demand, challenge individual prescriber gatekeeping, and hold regulatory bodies accountable for delayed implementation. Knowing that medicalized models produce benefits and that the required legislative and regulatory changes needed to satisfy this recommendation may take time, we recommend that the expansion of existing medical options continues to be a priority. This support includes increased funding for additional programs, long-term sustainability funding to break out of the pilot patterns, support for community drug user leadership and criteria and feedback processes for prescriber accountability, and support for provincial health authorities to develop public health models for safer supply. The production of a federal safer supply guideline could help to support and protect prescribers who are already offering safer supply while growing the practice through federal endorsement, incorporating the existing precedent of people who use drugs input into prescriber practices. The next recommendation was for urgent visible support for and upscaling of non-medical safe supply through co-ops, buyers clubs, or compassion clubs, and additional demedicalized and community-based options for safer supply. Presently, there were none of these clubs operating without having to assume significant legal risk, despite the universal understanding that what they're doing is what needs to be done. And the federal government must publicly issue support for these initiatives and provide resources for funding if that's what's sought out by the operators of this program. The onus lies with the federal government to offer an alternate mean for drug procurement aside from the dark web. So mimicking the pathways utilized to deschedule naloxone and applying that process to other medications and substances like benzodiazepines, cocaine, fentanyl, heroin, methamphetamine, and other drugs is a step the federal government should be taking. And the last recommendation for this slide is to implement emergency safeguards when and where provincial governments will not adopt safe supply or make investments in adapting safe supply models to meet unique local needs and contexts. While some provinces and territories have minimally explored medicalized safe supply models, Other provinces outright block safe supply due to political ideology. In fact, several provinces are promoting harmful regressive policies that reduce access to harm reduction and safer supply with misinformation and rhetoric. We call on the federal government to implement emergency safeguards, including funding and flexible legislative and policy approaches to prevent arbitrary restriction or cessation of safe supply and other harm reduction programs.
Yeah, and I think like that last point is a really is nuanced because of our national focus. Like it's not like we had a bunch of people from BC being like, we need this. We had people from Alberta and from Saskatchewan and other places saying we are in a completely different political climate than you are right now. And this is what we're seeing. And we were able to take those conversations and input them into like policies that would benefit the entire country, depending on where you are at and where your political views are at in your province. And I think like these recommendations are more like specific. So kind of an acknowledge, and implement, and a make. So we acknowledge that the CDSA's are racist and colonial roots, repeal it and replace it with a single public health framework for regulating all psychoactive substances as recommended by the expert task force on substance use. So that's a different group than this. There's lots of papers out there and lots of recommendations that have been made to the federal government on how to make things better. So taking what you already have and actually implementing it instead of more work to figure out what do people need. Implementing. In the interim, implement a nationwide Section 56 exemption to facilitate community-based safe supply. I think this one's really interesting because when we were reflecting on the DOLF program and us trying to get an exemption 56, I was thinking a lot about Insight and Insight getting that exemption and how it led to no one else getting an exemption for a very long time because it really was just for that one site in one place, and it didn't scale up harm reduction in or drug policy in a way that we needed. And us fighting for Dolph and Van Dew to have a compassion club was important, but we didn't have that scale. It didn't scale. It was one and one time. And even if we do this judicial review, which we are still in the process of, we will get one, not a bunch. And so making sure that we change the system, that there's more broad exemptions would be really beneficial. And then the last one here is to make benzodiazepines, cocaine, fentanyl, heroin, methamphetamines, and other drugs available to buyers clubs or compassion clubs. So, one of the big things that was coming up is that especially with Dolph, I'm sure you've all read the news, is that it's an illegal system and they're purchasing through an illegal system. When we had those conversations with the government, they had no solutions on how to scale up the creation of these drugs in our actual country. And we're actually asking Van Dew and Dolph to look into those options and come back to them. We're small organizations. We barely make any money. I make less than a lifeguard in the city of Vancouver. That's ridiculous. This is literally your job to figure out how our system expands or doesn't expand, and you should be doing that work as the federal government.
Now we're interested in looking into what next steps can be, and one of the parts of those next steps is to share this brief, which is why we're here today. We wanted the opportunity to let you know that it exists, it's publicly accessible, and that we want to hear from you about it. And so when we get closer to the end of this, I'll post the links so that you can have access to the full thing. If you do that at the beginning, then everyone just reads the brief and doesn't listen to you. We're still seeking feedback too. So we have a pretty large group of individuals who have reviewed and who have approved the brief, and we certainly are making sure that this is something that is led by and led alongside people who use drugs, but we could always use more feedback, and we could always use more opportunities to improve on it, and also how to capitalize on the brief or how best to use the brief. To that end, we're also thinking about what is the future of the actual society that was put together. It was organically developed. It came together for a specific reason. And so we're interested to see if there's utility in keeping a group like that going, and what role could it play. And then lastly, we're continuing to pursue meetings with the new federal minister of mental health and addictions, who has acknowledged receipt of the brief at very least, and has put us on her list. So I want to thank everybody for coming today. We have time for questions, and then we've got some discussion questions to hopefully hear from you afterwards. But for this moment, I'm just going to pause, stop sharing my screen, give space for questions, and I'll put the brief into the chat.